Hi everyone, welcome. Thank you all for being here this evening. My name is Stephanie Fortunato and I am the Senior Program Manager down at Cancer Support Community of Greater Philadelphia down at our Philly Ridgeland location. So we're grateful to all of you for being here and to CTCA for hosting us this evening and providing such a wonderful location for this event tonight. So just a few housekeeping things. We are recording live via Zoom. So we do have people watching who are not here with us this evening, which is a great thing, for people who couldn't make it. We've done this in the past. It's been very helpful to people who maybe they're not feeling well, but they still want to be able to have access to these resources and information. So we're excited that we've been able to do this at many of our lectures. So just a few things about being on Zoom. We're going to be showing the PowerPoint this evening. Dr. Crilley is going to be giving our presentation. I will be behind the scenes. We'll be taking questions on Zoom. There is a chat feature for those of you who are logging in remotely. And I will be sending a link to our survey at the end of the night for those of you who are logging in remotely. For those of you who are here with us in this room, you do have a survey. You should have a survey in front of you. If you don't, let us know. We do have extras. Everyone here can fill out and hand in that survey at the end of the evening. And it is incredibly important to us so that we can share that with our national organization and continue to improve these lectures. So I think that might be it from me. So without further ado, I'm going to introduce Nancy Hess, who is going to talk about CTCA and our speaker for this evening. Nancy.
Thank you, Stephanie, and welcome everyone to CTCA tonight. I see people I know and people who are new to me, so welcome and make yourself at home. And tonight I have the privilege of introducing Dr. Pamela Crilley, and she won't like that I'm reading this, but I think it's really important that you hear her pedigree and hear a little bit about Pam, because she is really an extraordinary person. And I've only known her for 5.5 short years, but her history in the area of oncology and her expertise has been going on for far many more years than I've known her. And when you hear what she's accomplished in her time, and actually I went to print out her CV, and her CV is not 20 pages long, it's more in the up to the 30+ pages long, so she's quite an accomplished woman. I'm very proud to work with her. Pam's personal goals are to provide the most personalized cancer care to each patient, to use targeted therapies, innovative technologies, and a multidisciplinary approach that encompasses the integrative and gives the patient hopes and goals for each one of her patients. Pam comes to us. She is board certified in medical oncology and internal medicine. She earned an osteopathic medical degree from the Philadelphia College of Osteopathic Medicine. Dr. Crilley completed an internship and internal medicine residency at Delaware Valley Medical Center in Bristol, Pennsylvania. She then completed a hematologic and oncology fellowship at Hahnemann University in Philadelphia, where she served as a chief fellow. Before studying medicine, Dr. Crilley received a bachelor's degree in English literature from Temple University. She's also a Shakespeare expert. That's not written in here. I know it. Dr. Crilley held multiple academic and administrative positions at Drexel University College of Hahnemann University Hospital, including the division chief and clinical service chief of hematology and medical oncology. She also served on several committees at Hahnemann University Hospital and currently serves as a professor of medicine at Drexel University College of Medicine in Philadelphia. Dr. Crilley has been featured physician in Best Doctors in America and the recipient of awards for her excellence in clinical care. Her research and work has been published in extensive American Journal of Hematology, Journal of Clinical Oncology, Blood, and other clinical journals. Additionally, she has served as an editorial board member for the American Journal of Clinical Oncology. She has also presented on breast cancer, acute leukemia, and bone marrow transplantation at numerous clinical conferences. Dr. Dr. Crilley belongs to several professional organizations, including the American Society of Clinical Oncology, the American Society of Hematology, and the American Society of Blood and Bone Marrow Transplantation. Pam serves here at CTCA as the Chief Medical Oncology for Cancer Treatment Centers of America across the country. She's instrumental in developing our clinical pathways, and she has been very influential to our medical staff as well as the entire medical staff across CTCA, which serves 5 different sites in the country. So Pam, I can't wait to hear what you have to say. She's well known here and well known across the country. Welcome, Pam.
Thank you very much. That was thank you for the introduction. That was very kind. I'm actually going to talk about acute myelogenous leukemia, and I just want to say that over the many years that I've been a hematologist-oncologist, which I have to say is 39 now, which is quite a while, I developed really early on a strong interest in the hematologic malignancies as actually a medical student on an inpatient service at Hahnemann, where we had about 15 acute leukemics at the time. And I was drawn to the fact that the patients developed very strong relationships with the staff, with the physicians, the fellows, the residents, the nurses, and all those who cared for them. And also that their diseases were very intense. They could be very sick and then get better, and we were always trying to go for a cure. And that passion for such patients has really gone through all the years that I've actually taken care of patients and had the privilege to take care of patients with acute leukemia and the hematologic malignancies. So tonight I'm going to focus on the topic of acute myelogenous leukemia, and I'm going to talk about what it is, how you make the diagnosis. If you're a nurse or a doctor and a patient comes in with certain complaints, how do you actually work up a patient, with acute leukemia that you might suspect? And is it acute myelogenous leukemia or acute lymphocytic leukemia, which are the 2 main types of acute leukemia? There's also chronic leukemias with chronic lymphocytic leukemia and chronic myelogenous leukemia, which behave in a very different fashion. So to start out with the definition of AML, what is AML? AML can either be called acute myeloid or acute myelogenous leukemia, and the word myeloid or myelogenous means bone marrow. And acute means that usually it comes out of nowhere. Somebody is fine and then they start to get symptoms, or they have a blood count. I've also had patients who've had a white count of over 150,000 who are asymptomatic and had a routine blood count. But some patients will come in with symptoms which can be non-specific, but may lead you to the diagnosis. And myeloid means that these cells come from the bone marrow and they're not able to mature properly, and they actually are malignant cells. And leukemia means that they're really white cells, but it's also, and it can be platelets, it can also be red blood cell types. And so it's not that common. The most common form of leukemia is chronic lymphocytic leukemia, which also tends to occur in older adults. There's about 21,000 new cases of AML in the United States yearly, which is not that high. And acute lymphocytic leukemia is much more common in children. And there's extremely high cure rates now for acute lymphocytic leukemia in children, less so in adults. The average age for AML at the onset of diagnosis is actually in older patients. The average age is about 68 years old. There are patients who are younger. There's patients in their 20s, some patients in their teens, but the majority of patients are actually older. And this can also result as acute, never had any prior hematologic disorder, or it can be something that evolves from prior treatment. For example, somebody had a certain type of malignancy who received either chemotherapy with alkylating agents or radiation therapy. They may get a secondary acute myelogenous leukemia, which behaves biologically somewhat different and can be somewhat more aggressive. There's also other blood disorders that may precede this. Most common might be myelodysplasia, and I'll talk about that in a few minutes. So some patients may have low blood counts for a couple of months and actually be diagnosed with myelodysplasia, which means that the cells in the bone marrow are not maturing properly. And that can be a low white count, a low hemoglobin, or a low platelet count. And some of those patients, the minority, will go on to develop acute myeloid leukemia. Now, what are some of the risk factors or etiologies that may lead to the diagnosis, or some of the causes that we know of? We don't know all the causes of AML, but one thing that we do know is that benzene exposure can cause it, ionizing radiation can cause it. I don't really think smoking can cause it, but some of the genetic disorders, some of these are autosomal recessive genetic disorders that may predispose to bone marrow failure states. And some of these are Down syndrome, Bloom syndrome, Fanconi's anemia, which usually has a low hemoglobin, and pancytopenia, which is decrease in all three of the blood cell lines. And also Li-Fraumeni is another predisposition to a low bone marrow failure state. And the pre-existing hematologic disorders, which are most likely to result in acute leukemia if they do, myelodysplasia, MDS, myeloproliferative disorders are where the bone marrow makes too many cells. Now, these patients may present with a high white count. Remember, the normal white count is about 5 to 10,000. These patients may present with counts that are actually higher than that, high hemoglobin or a high platelet count, or some combination of 1, 2, or 3 of those. And in that particular case, there's 4 subtypes of the myeloproliferative disorders. Polycythemia vera, you may have heard of, which is where they tend to make more hemoglobin and hematocrit, so they tend to have a higher red blood cell. You can also have essential thrombocytosis with a high platelet count. Normal platelet count's about 150 to 450,000. They may present with 1 million platelets, 2 million platelets, and that's called ET, or essential thrombocytosis. You can have chronic myelogenous leukemia, which has a specific translocation, and that can also transform into acute leukemia, and also myelofibrosis. So those are the 4 myeloproliferative disorders. Most of them do not go into AML, but it is a risk factor for those disorders. There's also a disorder called PNH, which is paroxysmal nocturnal hemoglobinuria. And in a subset of this, which is really a hemolytic anemia where you break down your red blood cells, there's actually an aplastic anemia component. So these patients may present with a low platelet count and a low white count and a low hemoglobin as well. And then, as I mentioned, there's treatment-related AML where you've had prior alkylating agents, for example, etiposide or Cytoxan or doxorubicin. Sometimes they may lead to AML. This is actually a schema of the maturation of blood cells that start in the bone marrow. So the hematopoietic stem cell is the baby cell that gives rise to all types of cells. That is white cells, red cells, and platelets. And now this particular type of cell is a small percentage of what's in the marrow, maybe only 3% of the cells, but it's the only one that can reproduce itself and also can go on to mature into all the cell lines. So for example, you can go from the hematopoietic stem cell to the lymphocytes or to the myeloid cells. The lymphocytes go on to be B lymphocytes or T lymphocytes, which are subsets of lymphocytes. And they can then mature to plasma cells. This is the normal maturation, excuse me. Now, in terms of myeloid progenitors, this can go to what you typically will see in the peripheral blood. Neutrophils are the white cells that fight infection, and usually about 60 to 70% overall. And then eosinophils, basophils, monocytes, platelets, and red cells. Now, if there is a malignant component to any of the maturation of these cells, here's what you get. For example, if you develop an abnormality that leads to acute lymphocytic leukemia, or ALL, this is where it starts. It's very early in the maturation scheme. If you go on then, you can develop in a more mature cell, chronic lymphocytic leukemia, which is CLL, or lymphomas. And the ultimate maturation is plasma cell abnormality or malignancy, which is multiple myeloma, or Waldenstrom's macrogammaglobulinemia. So that's the lymphoid if it goes awry. In terms of the myeloid, you can go on to have acute myelogenous leukemia, and that's where it would start. So it's a very young cell with AML. And then you can go on to some of the myeloproliferative disorders that we talked about, like polycythemia vera, CML, or ET. Now, what are some of the symptoms that a patient may present with who in fact has acute leukemia? Patients may come in with very non-specific. They're tired. Who is not tired? We're all tired. So they may be tired, but it seems like it's getting worse, and they have to rest more, or they can't really do what they're doing, or if they're playing tennis, they can't play, they're winded. So sort of tired, non-specific. Some people have weight loss, although that's not that common. Some people can have fevers. This can be low-grade fevers like 99, 100, 101, or they may present with a serious infection because they have neutropenia, where their percentage of neutrophils that fight infection is really low. So they may present with shaking chills, fevers, pneumonia, urinary tract infections, serious infections. They also can have shortness of breath, and this tends to be from anemia. So their hemoglobin is low, and they're tired, and it's just more of an effort to do anything. They may also have bone pain, more common in ALL than in AML, but some patients with AML may have bone pain, especially in the lower extremities. They also may have lymph node swelling. Patients may have palpable lymph nodes in the neck, cervical, supraclavicular, axillary. More common in acute lymphocytic leukemia, but can occur in AML. They also can have enlargement of the spleen, because that's actually a blood organ. And that's an organ in the back, retroperitoneal, in the back of the abdomen, but it may present with feeling full after you just eat a little bit, haven't had that much to eat. Also, they can have enlargement of the liver, and this is actually leukemic infiltration in those particular organs. Also, patients may develop night sweats in AML or ALL. They also may have easy bruising or petechiae, which are those little tiny red dots, and that generally means they have a coagulation problem associated with the acute leukemia, or they have a low platelet count. And the normal platelet count is about 150 to 450,000. Thrombocytopenia is anything less, but usually petechiae are about 50,000 or less, certainly much more common, 20,000 or less platelets. So some of the patients may have some patients may have none of this, and they just sort of have a low count, and they just don't feel right. It's kind of feeling unwell. And really the best way to really check this is to do a blood count. And so you usually see anemia, usually see neutropenia. So the white count can be normal, low, or high. Some patients, I think the highest I've ever seen with AML is 350,000. Patient was a elderly woman, came in, and she was like, it's a little bit tired. It was 350,000 white count. And it was basically all leukemic cells in the blood. And she had almost no neutrophils. So she did not have any defense against infection. So what you want to know is, what is the white count and what is the differential? Differential meaning, what are those cells that are in the blood? You have to really look under the microscope and see what they are. And patients usually have some form of thrombocytopenia. It may be 2,000 platelets, maybe 40,000, but some kind of thrombocytopenia. So as I mentioned, very nonspecific sometimes. So if you suspect, the doctor suspects acute myeloid leukemia, what do? Basically, you're going to look at the blood smear. Very important to look under the microscope and have a good hematopathologist as well. And patients are going to need a bone marrow. Most bone marrows are done in the posterior iliac crest. Rarely do a sternal anymore. So it would be from the posterior iliac crest. And what you're going to do is you're going to make an aspirate to take a look at under the microscope. And you're also going to do special studies on it, including flow cytometry, which will look at the markers on the leukemic cells. And you also want to do what's called FISH, fluorescent in situ hybridization, which is a sophisticated form of cytogenetics, because cytogenetics will give you a lot of information about the acute leukemia, whether it's AML or whether it's ALL. And also you want to look at some of the molecular tests that have come out in the last few years to see whether there's certain markers there that may then be useful in decision making in terms of the best treatment. And PCR and DNA sequencing and next generation sequencing are also being looked at in this particular setting. And you're not going to get these back right away, but it usually takes a couple of days. But sometimes you have to treat them anyway. There's a couple instances, and I'm going to talk about a little bit later. There's one subtype of AML, M3, acute promyelocytic leukemia, that is really a hematologic emergency and should be treated right away before you have everything back. And I'm going to talk about that in a few minutes. But generally, if somebody comes in with a really high white count, you have to get that white count down, because what can happen is they can have symptoms of what we call leukostasis, which means that the white cells essentially are clogging up the bloodstream and may cause cerebral problems in the brain with bleeding, also can cause respiratory failure. So it's important to see what the count is. I'm very visually oriented. It's one of the reasons I got interested in this. And so this is a normal blood smear that you can see here on the left. And you can see that those are, the bigger cells are neutrophils. These are the good cells, the white cells that fight infection. You can see the red cells are normal. And then there's a couple little dots. Those are platelets that clot the blood. Here's a peripheral blood smear with acute myeloid leukemia in it. And this has, you can see, fewer platelets, has a few giant platelets, but has these extremely large cells. And the leukemic cells are the blasts. They're called blasts. And the big characteristic of this is that usually they're in AML, they're big cells. Most of the cell is actually the nucleus. And then sometimes there's granules in what we call the cytoplasm, which surrounds the purple part. And so this is really a diagnosis you can make on a peripheral smear. So how do you say you have acute leukemia for sure? You have to have greater than 20% blasts in either the blood or the bone marrow. So somebody actually sits there and counts how many cells there are. They'll count 200 cells in the marrow and look at the percentage of cells, and has to be at least 20% in the blood or the bone marrow or both. The next thing is you're going to look at the cytogenetics, and this will take a week, sometimes a little bit longer to come back. Crucial to make a decision about what you're going to do later, because you're going to give upfront treatment and then you're going to give more treatment based on the cytogenetics. Some examples of chromosomal abnormalities in AML are the 821 translocation, inversion 16, and translocation 1517. Very important information. And also you're going to look at the immunophenotype, which is really the results of the flow cytometry that you do on the blood or bone marrow cells to find out what those markers are to subcategorize the type of AML. And you're also going to look for something called Auer rods. Auer rods are granules that tend to be stained pinkish red, and mostly in the cytoplasm, but sometimes as well in the nucleus. And I'll show you some pictures of that. This is a bone marrow aspirate, essentially all blasts. So how do you subcategorize AML? There's really two sets of classifications. The first is the FAB classification from 1976. This is the French, American, British classification, which looks at, had some hematopathologists and physicians get together and decide, how do we subcategorize this? Does it matter what subtype you have? Does the treatment differ based on the subtype? And so they looked at cytochemical stains and what the cells look like under the microscope. First of all, to say the difference between AML and ALO, because the treatment is very different. After that, as more sophisticated testing became available, the WHO, or World Health Organization, in 1999 started to incorporate chromosomal abnormalities and also how much dysplasia, that is how abnormal the other cells looked in the microscope, under the microscope, when differentiating 20% blasts. This was then revised again in 2008 and again in 2016, and has more and more molecular studies in it to subcategorize AML. So what are some of the clinical features that you might be able to see? Well, there's bone marrow involvement, as you know, tissue involvement, and there's some rarer presentations that tip you off somebody has AML. This is a comparison of a typical look of acute lymphocytic leukemia on the left and acute myeloid leukemia on the right. And you can see that on the left, these ALL cells are big, but they're almost the entire cell is the nucleus, but there's not a lot of granules, which are the little red dots. On the right, this is typical AML with large cells as well, big nucleoli, but also lots of granules in the cytoplasm. So if you looked at those under the microscope, that's what you would probably guess they were. But obviously, you have to do the other tests to be 100% sure. This is another example of AML, and I just want to really point out the rods that you can see in the right in some of those leukemic cells, which are our rods. If you are in a hospital way far away on a mountain and you don't have a hematopathologist and all the sophisticated stuff, somebody comes in with a white count of 150,000, and you see a peripheral blood smear that looks like this, as soon as you see an hour rod, that's AML, period. So that if it's in a medical emergency, as it would be if it was a really high count, and you have to treat the patient, you could treat them and make the diagnosis that way. So it's very distinctive. What are some other things that you can see clinically? Patients may have bone pain or bone tenderness. Some patients may have sternal pain, hip pain, splenomegaly on exam. They may complain of that, or some back pain. And I'm going to show you a picture of gingival hyperplasia, which is where the leukemic cells infiltrate into the gingiva in the mouth, and it's worth a picture. This is what it looks like. And if you see this, it's also very suggestive that it's AML. And so what happens is if you treat the patient for AML who has this, the next day it'll be gone. It's just, it's very, very sensitive to the treatment. And I've seen this a couple of times. It tends to be more in the monocytic type of AML, which does have what we call extramedullary manifestations. One time I saw a patient with this, and we took a picture and got the patient's permission and decided to send it to the New England Journal of Medicine for a picture. And as we went, the day we sent it, it came out in New England Journal from someplace else. But it's so distinctive. And it's something that if you want to show a medical student, because if you see that, you have to do a blood count. There's also some skin features that we have. One is Sweet syndrome, and I'll show you a picture of that. That's an inflammatory reaction that has a certain look on physical examination. And then there's leukemia cutis, which is actually infiltration of leukemic cells in the skin. And I'll show you a picture of that. The thing about it is, again, if you treat the AML, it goes away. And then there's chloromas, which are basically a lump of AML. Now, chloroma may be any place in the body. It may be palpable. It can present with a cord compression, which is actually a lump of AML present on the spinal cord. You can also have papilledema and CNS involvement. On the left here is leukemia cutis, and on the right is the Sweet syndrome. That's what they look like, and they go away when you treat the patient. Now, some other things that you want to think about when you have a new patient with AML is coagulation. Some patients with AML may have something called disseminated intravascular coagulation. This is where they may have a tendency to clot or bleed, more commonly bleed. And so they may have a prolonged prothrombin time in PTT and a low fibrinogen. And these are tests that are essential to do up front. A patient may either present with this or they may develop it as you treat them for the AML. You also want to check their kidney function, because if you're going to give somebody chemotherapy, you want to make sure they're going to be able to excrete it. If they have a really high creatinine to begin with, they may need to be leukapheresed or actually have a physical removal on the apheresis machine or the white count. Get the white count down and try to hydrate the patient before you treat them. So you have to watch their electrolytes. They can get tumor lysis syndrome. And it's really important that people taking care of these patients know what they're doing and are able to intervene when they need to. This is the subsets of the FAB classification of AML. It's basically 0 through 7, and they mostly are treated the same way except for M3. So the treatment depends on the age of the patient, and many of these patients are older with comorbid illnesses. We just saw one recently who has renal failure, hepatitis, liver problems. So you have to take all that into consideration because this treatment is not easy. You also want to look at the medical history if they've had prior treatment. For example, with chemo, what did they have? Did it affect some of their organs? And so these are things to talk about with the patient, and age is really one of the most important things. It's also important to choose your healthcare team who is experienced. You need pathology, you need blood bank, you need a good hematologist-oncologist, you need infectious disease. You need a lot of people to be able to take care of patients such as this. You need a lot of staff, and you really need very well-trained nurses who are also passionate about taking care of these patients. And you also want to make sure that you have a good relationship and you can ask questions and you can feel very comfortable speaking to your staff. And these are not the most common diseases. You know, obviously the solid tumors are more common, but they're very specialized in terms of treatment. And I think it's also very important that you be able to ask any question of your healthcare team and to say if there's anything else you're on medication-wise that anybody else gave you, any of your other doctors, so that the doctor can decide whether or not there's any interactions that may affect the efficacy of the treatment. And also what some of the benefits are, what your goals of therapy are, and some of the things like that. Again, a couple of pictures. This is actually cerebrospinal fluid of a patient with AML in the central nervous system. Here's another example of it. And this is actually an example of a peroxidase stain. This is an immunohistochemical stain. And this is a positive stain with all the little brown dots for peroxidase. Just as an example, confirmation. If there's more than 1% of this, it's AML. I want to talk a little bit about acute promyelocytic leukemia. This is a extremely curable AML. This is the one that has multiple hour rods, and you can see all those little rod-like structures are all granules kind of in a rod. The danger with this is that they have usually or very often have disseminated intravascular coagulation. A certain number of these patients will die before they see anybody, and it has to be recognized by somebody right away before something happens. So these patients, if they don't have DIC, will get DIC, and so they have to be supported early on. So, and the cure rate is now extremely high. Just to reconfirm how important cytogenetics is for patients with AML, this is the single most important prognostic factor to take into consideration when you're treating a patient. And these patients may have monosomies that are unfavorable, such as deletion 5, deletion 7, certain abnormalities that may make you think about doing a transplant as part of the patient's treatment. This is the chromosomal abnormalities just put into favorable and unfavorable categories. Favorable includes 15-17, which is AML-M3 promyelocytic. 821 and version 16 are the sort of favorable group. The unfavorable, there's more of those, deletion 5 or 7, and also 11q23, translocation 6-9, and 3q and FLT3 mutations. Some of the patients with deletion of 5 or 7, you would have to consider for an allogeneic transplant upfront. And also we look at what is the response to treatment. When the patient starts with treatment, which is chemotherapy, and I'll talk a little bit about what chemo they get, you want to look at what is the response. So you start out with the bone marrow up front, you have over 20% blasts, and then you do another marrow about 7 or 10 days later, and you're looking for less than 5% blasts on that marrow. If you don't have it, you may have to do a second round of induction. If somebody has greater than 20% blast at 7 to 10 days, that's an adverse prognostic feature. And again, age, which is characterized as greater or less than 60 years old. Pregnancy is a special case. There are patients who present who are pregnant with acute leukemia. There are certain drugs you cannot give for patients who are in the first trimester. In the second and third trimester, you can, but it's a very special, and you have to work closely with GYN. And then there's also treatment at relapse. So what are the treatment options? The main treatment is chemo, basically, chemotherapy. And the goal, again, of the treatment of AML is cure the disease. Sometimes we have patients who come in and we know that we're not going to cure them with certain diseases. AML, you're always trying to cure the patient. So you sit down with the patient and you talk about, how do I get there? What do I have to do? Targeted therapy is another option with patients, usually at relapse or on some clinical trials. And stem cell transplant may be part of the treatment. It's not the upfront treatment. All patients have induction first. And clinical trials, of course, are extremely important. So remission is what you're looking for. Complete remission is defined as the bone marrow returns to normal. So the count that was abnormal is now going to be normal. You have over 1,000 granulocytes, hopefully a normal white count, hemoglobin at least 10, and platelets over 100,000 with less than 5% blasts in the bone marrow that lasts for 30 days. That's the definition of CR. If you don't get to CR, you don't go all these other paths. You have to go to another round of another treatment. But first, you must achieve complete remission. And after that, you then decide whether you want consolidation, which is more chemo, or transplant or not. And when you start out, you may have 10 to the 12th leukemic cells in the body. By the time you do CR, you still have 10 to the 9th. So you may not see them anymore. You may do a marrow, but they're still there. And that's why you have to have more treatment. Any questions as we go along? Feel free. So chemotherapy is obviously a big deal. Most of the patients who get induction chemo are in the hospital if they get standard induction. And it can damage other cells, so there's other side effects. The two biggest dangers with the induction treatment for AML are infection and bleeding. So we have much better antibiotics than we had before. We have much better platelet transfusions, red cell transfusions. We know how to take care of DIC. And so those are the issues that you worry about. And also, I think some patients come in and do not get that sick. Other patients get extremely sick. So after induction, the next phase, if you enter CR, is called consolidation. So that means you're trying to get the rest of those cells, the 10 to the 9th or 10 to the 8th cells, down to 0. So that may be several more cycles of chemo, or it may be a transplant. And there's autologous transplant where you use your own cells. And there's also an allogeneic transplant, which is from somebody else. And that could be a sibling, a family member, or an unrelated donor. These are some of the drugs that we use for the induction for AML. Cytosine arabidoside. This is basically 7 and 3. Okay, so it's 3 days of the anthracycline and 7 days of cytosine arabidoside. And you can use one of 3 anthracyclines. We have daunorubicin, doxorubicin, and idarubicin. And also, if you have a treatment-related AML or a prior MDS, there's a new liposomal formulation of daunorubicin and cytosine arabidoside together that's been FDA approved recently. So the next step is for your physician to discuss with you the consolidation. And some of the consolidation can be done as an outpatient, and some of it is totally inpatient, depends on the status of the patient. Now, some patients can't tolerate standard induction chemo, because remember, a lot of these patients are older, they may have other comorbid illnesses as well. So some of the combinations with what we call low-dose chemo are things like the hypomethylating agents, which are azacitidine and decitabine, which can be given as an outpatient, with venetoclax, which is a newer drug in combination. In the past, it's been primarily azacitidine or decitabine alone, but now we're using combinations, and also low-dose Ara-C. Patients who take these may still have to come in the hospital for an infection, but generally it's tolerated as an outpatient. And targeted therapy is where you're actually trying to decrease the leukemic burden, but it causes less peripheral damage, some of the lesser side effects. Or sometimes we add the targeted agent to chemotherapy as well, particularly for somebody that we consider high risk. And for treatment for older patients, tend to use the hypomethylating agents or the liposomal combination. And this also has to do with patients who present with poor risk cytogenetics but can't tolerate a transplant. These are some examples of some of the newer drugs that are used in the cases of patients who have a relapse or refractory disease. Relapse means you entered CR, but at some point the leukemia came back. Primary refractory means you got induction, you may have gotten a second induction, you never entered remission. And those patients it's very difficult because they've had long periods of neutropenia, and so it's very difficult. And some of these agents are oral, and we look for these mutations and then can target it with specific drugs. The stem cell transplant concept, for an autologous transplant, you're going to use 10 times the normal dose of chemo and give the patient back the cells that you already took out and basically give them back. And so they do not have any problems with immune rejection or graft rejection. An allogeneic transplant is where you're taking not only cells from somebody's marrow or peripheral blood, but you're also transplanting an immune system. So there's a whole different level of immunosuppression, potential for different kinds of infections, and more complex transplant. And so the sources for transplant can either be peripheral blood, where you collect the cells out of a patient's arm or a catheter, or they can be bone marrow, where somebody has a bone marrow harvest, where the cells are collected and then can be either given to somebody else fresh or frozen and then defrosted. And also possibility of umbilical cord is another source. For adults, umbilical cord, often we have more than one, usually 2 cords for an adult to engraft. And there's something called the National Marrow Donor Program, which I'm sure you've all heard of, being interested in AML, or Be the Match, where you have millions of donors who are going to donate their peripheral blood or their bone marrow for somebody they don't know and may or may not ever meet, which I always find astounding, even though I've been doing this for many years, that the patient, their donor comes in and, you know, they just really want to do it. And a lot of them are very young. I mean, the last 2 weeks, I've seen like at least 6. They're in their 20s, they're in college, or whatever, and they just want to do it. Some of them want to do it more than once. So one person I had, I was on you today, did it 3 times, but that's it. I mean, 2 is enough, 1 is enough. But it's amazing that they do it. And the thing that's really neat about the NMDP is that these cells can go anywhere in the world. So we, I think, recently sent some to Japan. You know, we've sent to Italy for babies. And so it's really worldwide, and it's growing. And so I think that's an amazing thing to have an unrelated donor transplant. So that's, you know, one option, and that again depends on the disease, the chromosomes, and what the CR rate is. These are some of the indications for an allogeneic transplant. First remission but bad chromosomes, younger but intermediate risk chromosomes, first relapsed, or CR2, which means you went into remission, then you relapsed, then you got more treatment and went into a second remission. They're at high risk to fail, so they can get an allo transplant. Primary induction failure, if they never entered CR, refractory disease. For older patients who can't tolerate an allo transplant, there's something called a mini transplant or reduced intensity transplant, which is primarily immunosuppressive. So for example, Cytoxan or fludarabine or low dose total body radiation. It's not high dose chemo plus, it's just the immunosuppression. They tend to have better outcomes in terms of less toxicity, but higher relapse rate. And this is just an example of a bone marrow harvest. This is where the patient has either, the donor has either general anesthesia or spinal, lies prone. 2 people operate, multiple aspirations under anesthesia, can be 150 sticks, for example. Take out a little at a time, and basically if you're doing it for an unrelated recipient, you take out what you need, you see what the count is. The recipient's physician decides how much they want, how many million cells, CD34 cells, and that's what you try to do. Some recent developments are combinations. These are more targeted agents, just to show you that there's some pretty good response rates here. Venetoclax, as I mentioned before, with decitabine or azacitidine, the hypomethylating agents in treatment-naive elderly patients who would have difficulty with standard induction, have actually a high remission rate overall, about 73%, even in patients with poor cytogenetics. So this is a relatively new but exciting result. And for patients with FLT3 mutations, which is an adverse feature in about a quarter of patients with AML who present, there's new drugs here as well. And also for the IDH mutated AML as well. And this is an oral agent. Just a last word on APL. Just wanted to say that for APL, and the reason I emphasize APL, it's such a unique disease. There's 2 types of APL. There's high risk and low risk. High risk is a high count, which is over 10,000. Most patients with APL present with a low count, so it could be 2,000, and they may have a couple of cells in the blood. Those who are high risk still recommended to have chemo, although it may not stay that way. And the low risk now, actually get basically a non-chemo regimen. There was a very important paper in the New England Journal of Medicine, which was a phase 3 study out of Italy, looking at all trans-retinoic acid, which is oral, and arsenic trioxide, which the Chinese figured out, in combination versus typical induction type chemo for this. And actually there was a complete remission in all patients who had all trans-retinoic acid and arsenic, all. And also, and the chemo group is very high as well. So this is now the standard of care for most APL, which is amazing, really amazing. Clinical trials, just want to finish on this. I can't overemphasize the importance of clinical trials. Not all patients with AML are cured. You know, we're doing better than we were before, but still we want to try to have all patients cured with AML. So clinical trials are really important. Some people are afraid of them. They think it's experimental, which it is in a way. But the reason for a clinical trial is to improve on the results that we have now. If it was 100% cure, we wouldn't have to do it. So I encourage patients to also consider clinical trials, particularly if they do not enter remission in the standard way, and at least explore this with their physicians. And I think some of the questions you need to ask in that case are, would I be eligible for it? What are the criteria? And what would I have to do? Where would I have to go, and how would it impact my family? The other thing about the treatment of AML is the side effects. It's important to talk to your physicians and your nurses about what the side effects are. Some of the newer therapies have different side effects than the regular standard chemo. And also, there's long-term side effects. You know, this is a very intense disease. It hits you usually out of the blue. You have intense treatment, and then you're observed. I find that a lot of patients, I was talking about this a little bit earlier, have difficulty returning to normal life because they felt like they were threatened. Their life was threatened, and now they're cured. So to try to go back to work and not have prejudice against a job, and also to, you know, back to your family relationship and working, I think it's a big adjustment. And I think that it's important that those of us who take care of patients with AML recognize this and recognize the fact that there are long-term complications. There could be heart failure, fertility problems, et cetera. A lot of these things you talk about with your physician up front, but I think also the long-term and taking care of yourself is really important as well. And so for follow-up, I know that I have some patients that I treated 20 years ago with acute leukemia who still come back because they still want to see that normal count. You know, so I said, well, you know, you were cured like, 15 years ago, but I just feel better when I come in and I see that I have a normal count. And we, of course, love to see those patients. So some of the things that you want to do is take care of yourself in all the ways that everybody tells you. Eat a Mediterranean diet, exercise, don't smoke, and stuff like that. That's important, I think, for your long-term care, to be very active. And I'm big on exercise for all patients who can do it. There's a lot of support available for patients with AML. I think that patients are becoming more and more proactive, seeking out some of these services. That's it. So any questions, I'm happy to answer. Yes.
So I have one. So a lot of the references in here to FLT3. And the one question I have is, when it comes to FLT3, isn't it true that there's like an unfavorable and then like another category which is not as unfavorable, if you will? But isn't it true that there's kind of like two different types of FLT3s?
Yes, and I think that it's really an example of how so much has evolved and changed. And I think from the clinical trials that have been done on FLT3 patients, I think we're learning more about that. And yes, there are definitely two separate groups, but I think in terms of the long run and the treatment, we still really have a long way to go. And I think it's true also of all of the other molecular markers that we have, and also the ones that are as yet undiscovered too. And there's also now looking at immune therapies, some of the immune therapies plus 7 and 3 or plus whatever. So the question is, where do the new immune therapies fit in the heme malignancies? And so there's clinical trials, looking at that, and some results are starting to come out that they may be additive. And the question was that going to really change the toxicity profile as well? Because the side effects are different, and are they additive or not?
Pam, what made you go from an English major to
Well, originally, honestly, my father was an artist, and we lived in New Hope, and so I was exposed to theater and music and art, and then I got interested in art history. But my father would do a painting, and then 6 months would go by before somebody bought it. So I thought, well, I'm going to do something more organized. So I actually wanted to be a veterinarian originally. I forget how I got there, and then I realized I was allergic to cats. I thought, well, that's half the audience. So, and then my grandmother got sick, and she had a stroke, and she couldn't really speak. And I went to the hospital a couple times with her, and I was struck by the difficulty she had communicating what she was trying to say and what her symptoms were, because she really couldn't, and trying to listen to her and watching how the nurses particularly, interacted with her. So I got interested in sort of the relationship of the staff and patient. And then when I was in college, I got interested in Shakespeare, and I spent a year in Rome studying art history. I was really interested in art history. And I think it all came together for me with leukemia and the visuals. And does that make any sense?
look at the cells, huh?
Looking at the cells, yeah. Yeah, it was like art, so. I think I learned a lot from Shakespeare about how to talk to patients, actually. Yeah, I think a lot of wisdom there. So.
All right, so here's another question. So through the years, you've been in Hemon for more than 10 years, right?
Yeah.
And technology has changed, the treatments have changed, and what do you think has been the greatest breakthrough?
In the heme malignancies? I think it's really a combination. I would say the things that jump right in my mind are drugs, new drugs. I think also much better supportive care. I think, even the advent of, red cell transfusions, platelet transfusion, better HLA typing, bone marrow typing, to be more specific and try to cut. So I think there's really a lot of things that have made a big difference. I think a lot of it is medications, drugs, supportive care. I think it's astounding, really. I think one of the things that really shocked me was the beginning of the tyrosine kinase inhibitors in CML. Chronic myelogenous leukemia was a disease where if you didn't get an allogeneic transplant within 2 years of diagnosis, you were going into acute leukemia, and that was it. It didn't respond very well. And then along came Gleevec, and I remember we did clinical trials with Gleevec with Johns Hopkins, and it was called ST something, and it was it worked. And it just now there's all these heme malignancies that are on oral agents, and maybe not all forever. They're on them for a while, and then they may stop again. So I think those are astounding changes, because now CML, people's taking high blood pressure medicine. Not that it's not without side effects, but it changes your life. You can go to work, you can do whatever.
Do you think that other drugs that are people have to be, that you said for induction, not people have to be inpatient for the whole time? Do you think it'll ever be where a lot of those drugs will be oral, so people won't have to stay in the hospital?
I hope so. I think, the other thing is with the way that transplant has evolved, again, with better immunosuppression, better antibiotics, I think that, yes, I think we have still not found the best way to give induction to AML. And I think it would be great to be able to have something oral. And I think it's possible, because I think the rapidity with which new drugs come out, the clinical trials are done, it's really hard to keep up with. It's just so fast.
They're really doing arsenic oral.
Yeah, arsenic oral, yeah. Well, who would think arsenic? I remember arsenic. You gotta give somebody arsenic. Yeah, arsenic and old lace, but it cures APL.
First they tell you you have cancer, and then they tell you that they're going to
You're going to give it arsenic. Yeah.
Right.
Yeah, that's right.
And so Pam, one more question. I've never had the privilege of being with you with families and with patients. what's your best counsel you give families who are going through this with a patient?
Well, I always say that I think that you should really feel like you're able to ask any question of anybody taking care of you anytime. And don't feel like anything is a dumb question, because it's not. And, you know, we may forget to tell you about something, or, you know, we may have told you, but you weren't ready to hear it. So I think communication is key. And the other thing is with acute leukemia, if they get a certain side effect, well, you better know about it. Like call, communicate. I mean, if they have a fever and they're 103 and they don't feel right or a little confused, you get them in. I mean, you have to be able to feel like they trust you, because remember, they're trusting you with taking care of them. I mean, it's a huge privilege to take care of them, but it's a big responsibility. And I think communication of anything you want to ask is really important. And, you know, I think they do, because I think that the relationship you get with an acute leukemic when you take care of them is amazing. It's just amazing. Right? Right.
What do you see as the most frequently occurring health issue for long-time survivors?
You know, I think when you think about the drugs that you get, it depends. Like if you get induction and consolidation, I think sometimes, you know, fatigue is an issue, you know, kind of long-term. Some people talk about chemo brain, or they feel like they're not as sharp as they were, which tends to improve over time. I think those are some of the things. If you have a transplant, for example, if you have an Allo transplant, and you've been on immunosuppression, or you develop graft versus host disease, you know, you may have long-term things like dry eyes, you know, where you have to put drops in. Some people have an increase in infections. So I would say those would be the things that would come to my mind. I don't think neuropathy is a big deal, and I don't think there's much cardiac toxicity because they're so carefully watched for that. And I think psychological is an important thing to think about and talk to patients about, because sometimes it's hard to say, I survived this, and I'm cured of this, and I'm having trouble dealing with the fact that I'm okay. You know, it may not sound like a lot, but it is, I think. So I think you have to talk to them about going back to work and exercising, and, you know, trying to get back. And then sometimes it's, you know, the relationship with the family is different as well. So you have to kind of get back into all that. And I think that's important to talk about, because some patients and sexuality, you know, I mean, patients sometimes ask you and sometimes they don't. And sometimes you can tell they want to ask you. So I think that's where the sort of connection, and you want to feel connected to the patient so that they'll ask you anything.
Have you noticed any kind of differences across genders in terms of how patients might either respond in terms of communicating? You talk about the importance of communicating with the physician, but also with families. Is there any difference that you may have noticed across genders, men versus women?
I would say maybe that women tell you more easily about how they feel, and men tend to be a little bit more reticent. Sometimes you have to try to draw them out. I think men are more reserved, or they don't tell you as much right up front, I would say. But otherwise, I think they're pretty similar. I mean, it's, you know, it's really a difficult thing to deal with, and it takes a while. And sometimes when you talk to somebody, you can see that they're not hearing you anymore. Like you're talking to them, like, especially in the beginning, and it's like you can see that they don't. It's enough. Like, that's enough for today. I got to talk about another day. So I think it's like communication and trying to see what they're really trying to say. They may not be quite saying, or they talk about something else, but they really mean this. But I think they're pretty similar.
Is it like that with compliance as well?
Yes, I think so. I think most patients are very compliant. It's rare for somebody not to do what you ask them to do with AML. And they have a lot of support. I mean, the nurses are a huge support for patients with AML. You know, inpatient, outpatient, you know, there's a big relationship there as well. So I think they feel like I think they do communicate. And again, it's because it's so intense, and it's so, you know, you see somebody every day for 3 to 5 weeks in the hospital, you do a transplant with them. You know, it's really a strong bond. That's it. Yes.
Thank you.